Thank you. Thank you, Linda. Good morning, everyone. Thank you for taking time out of your busy day to attend this webinar, HIV 101, What Primary Care Providers Need to Know About HIV. My name is Emily Bean, and I manage the Main Care HIV Waiver Program. Just a few quick housekeeping things. We will have time at the end for questions, but as we go, feel free to put any in the chat or Q&A section. This webinar is being recorded, and a link to the recording as well as the slides will be emailed to those in attendance and posted on MainCare's website. At the end, there's going to be one quick poll question. So as we conclude, please don't disappear too quickly. And today we have presenting with us Dr. Stephen Rawlings from the Gilman Clinic at Maine Medical Center. I thank you all again for your time, and I'll give the floor to Dr. Rawlings.
Oops, one quick. Thank you very much. Just pulling up the right screen. Thank you, everyone. Thanks for being here this morning. I'm happy to talk about HIV 101. I think just one small thing, I'm focusing this lecture for the time being on sort of just increasing testing and answering questions about testing with a little bit of information also about initial steps. And then we will probably hopefully do another webinar on a little bit more advanced management of HIV in the near future. I have no disclosures. As I mentioned, sort of learning objectives, I want to briefly review the state of HIV in 2024, although many times, as is the case for a lot of infections, we have data that's a few years older just to get complete data sets. Screening recommendations and some legal requirements around HIV testing in the state of Maine, testing algorithms and what it looks like to order a test and what you can expect to come back from your test site. Initial care and test to send after a positive diagnosis. And then while not totally on this topic, it's just I can't leave an opportunity to briefly mention PrEP and NPEP. So I want to start by talking about ending the HIV epidemic, a major push announced by the federal government in 2019. And their goal is to end the epidemic of HIV in the United States by 2030. This is an ambitious goal and includes sort of 4 pillars. The federal government has focused efforts on diagnosing all people with HIV as early as possible, and that's where testing comes in very importantly. Treating everyone, so once we've made the diagnosis, getting people into treatment and getting them on treatment that reaches a sustained viral suppression is incredibly important. For people who do not have HIV but are at risk of getting it, which could include essentially any sexually active adult, offering them information and prescriptions for PrEP or pre-exposure prophylaxis is a major way that we can prevent new HIV infections. And sort of a fourth, slightly more experimental pillar as well is fast and sort of overwhelming responses to outbreaks where there's an HIV in a network. For statistics around HIV diagnoses in the country, we're a little out of date. The most recent complete information is from 2021. There was clearly a decrease in the amount of tests done during 2020, likely due to the COVID pandemic. But we unfortunately are still seeing new infections at the rate of about 30 to 35,000 per year. This slight increase is thought to just be, like I said, the statistical anomaly of 2020, but it's decreasing, just not decreasing fast enough. Another important thing, in the United States, it's estimated that 1.2 million people have HIV, but only 87% of them even know it. So about 13% of people living with HIV don't know their status. And this is where testing plays an important role in increasing awareness just to find the people who don't know they have it so that we can get them into treatment. Briefly, the sort of a picture of the epidemic nationwide. You can see here in Maine, in terms of new diagnoses of HIV, people over age of 13, again, this is 2021 data. Maine is relatively low with only 2.6 new infections per 100,000 of population compared to other parts like the South of the United States, which have much higher incidence rates. Our prevalence is a little higher relative to our neighbors in New England with 141 positive people living with HIV per 100,000, but again, not nearly as high as other parts of the United States. And I'll talk a little bit more about Maine-specific information in a couple of slides. But I think it's just important also to focus on the Demographics of new infections. So again, from the 2021 data set, we see that about 80% of new infections were in men, cisgender men. But it's worth pointing out that almost a 1/5 of new infections are in women, cisgender women. We're also seeing that heterosexual contact accounts for almost a quarter of new infections. So I think some of the old preconceived notions around HIV transmission are important to disregard and focus on any possible way that HIV can be transmitted. Injection drug use is also one that's rising that we're seeing as a means of HIV transmission. Also, new diagnoses are not just limited to younger individuals. About half of people were over the age of 34 when they were diagnosed with HIV, including 10% who are 55 and older. So this just reinforces, and something I'll talk about again later, but the need to screen individuals of all ages. Related specifically to Maine, our complete data is from 2019. 29 new cases of HIV were reported that year, diagnosed. 72% of those were in cisgender men, 22% were in cisgender women, and 37% of our HIV cases are already presenting with AIDS when they're diagnosed. We have approximately 1,700, 1,800 people living in Maine with HIV, and they're split roughly half of them having an AIDS diagnosis, which you carry an AIDS diagnosis anytime you've had an opportunistic infection that's AIDS defining or a CD4 count less than 200, but many times on treatment, the CD4 count will rise above and we can cure those opportunistic infections. 93% of Maine's population identifies as non-Hispanic white, but of people living with HIV in Maine, it's a little bit more reflective of the national trends. So 19% are African American, 7% are Hispanic or Latino, and 18% were born outside the United States. So worth keeping in mind too that the demographics of the people with HIV in Maine is a little bit different from the demographics of Maine as a whole. Compared to other states, I think we have two things that kind of make it very difficult to test and identify HIV, but make it important to do it. So Maine has the 4th lowest incidence of HIV in the United States, which just kind of means it sometimes falls to the back of people's mind. We don't see very much HIV. But it turns out in 2019, Maine was 49th for the percent of patients who already had AIDS when they were first diagnosed. So this basically means that people are living too long, effectively, with HIV and progressing to AIDS before their diagnosis is made. And we need to be doing more testing, more screening, and diagnosing those individuals sooner. So 37%, as I mentioned, of people diagnosed with HIV for the first time in Maine already had stage 3, which is AIDS, and the national average is 20%. So we were behind 48 other states in the nation in terms of that proportion of people who already had AIDS when the diagnosis was made. There's also an interesting statistic that I haven't fully figured out, but we have a very high death rate of people who ever had a diagnosis of AIDS. It's 2 to 3 times higher than any other state in New England. This may be a feature, as I showed you also, that we have a higher prevalence, some more people living in Maine with HIV than, say, Vermont or New Hampshire. But it's just another piece of the puzzle as we try to respond to people with HIV in Maine. When we talk about HIV care and testing, it's actually very important to understand the HIV care continuum. This is a concept of sort of an entire spectrum of keeping people healthy when they have HIV. So it's very important that we diagnose all people who have HIV so that they know about it and can be engaged in care, promptly link those people, new diagnoses, with care, and relink people who fall out of care into HIV care. We want to get people on medication after they've been linked to care. We want to keep them in care and relink if we need to. And very importantly, although very achievable, is get to viral suppression when you have HIV. And when these data are looked at, or these metrics are looked at nationwide, we unfortunately start to fall off at every stage. So as I mentioned, of the 100%, say, of newly infected people in the United States, say 40,000 per year, only 87% of those are diagnosed. We end up only linking 75% of the 40,000 to HIV care. retain about 57%, and then we can usually keep those, anybody retaining care as undetectable, but we're losing a lot. And so this leaky pipeline allows for people to continue having HIV, continue the risk factor, the risk of immune suppression that gives them potential for developing AIDS and even dying of an opportunistic infection. It also increases the risk of transmission. One important piece as I'm talking about transmission that's also just important to share with patients who have a new diagnosis or didn't know about it before, know about this feature before of their HIV. When people living with HIV have an undetectable viral load, or more importantly, a suppressed viral load, anything less than 200 copies per milliliter, if they're taking their medicine every day, they are untransmittable. So they cannot give HIV via sex to another person. And I think this is very empowering. It helps people kind of really own their diagnosis, own their life, but also make their partners feel much more at ease. So transitioning a little to screening and the screening recommendations for HIV, the CDC issued guidelines in 2006 and largely hasn't updated them, though in 2017 they issued sort of a reaffirmation that the guidelines should be what they say in 2006. So the CDC recommends an HIV test for all persons aged 13 to 64 in all healthcare settings. This is sort of a one-time test, so at least once somebody aged 13 to 64 should have an HIV test. Any person newly diagnosed with tuberculosis should have an HIV test, and anybody seeking treatment for a sexually transmitted infection, including anybody attending a sexual health clinic, should have at least one-time HIV test. The CDC goes on to recommend additional screening, which can be as frequent as every 3 to 6 months, for any person who injects drugs and has sex with somebody who injects drugs, any person who exchanges sex for money or drugs, any person who is a sex partner of somebody who has HIV, and any person who's had more than one sex partner since their last HIV test. So really, this is getting at risk behaviors, which it is important to assess in your patients and understand what risk behaviors they may have for HIV. And these also feed into PrEP recommendations, by the way, which I mentioned I won't totally have time to go into, but these are people who should absolutely be receiving extra information about PrEP. In 2019, the USPTF also issued recommendations, largely confirming the CDC's recommendations, but because it was a USPTF recommendation, it helps with insurance coverage and reimbursement for testing. So a grade A recommendation from the USPTF was again given to screening for all adults 15 to 65, at least once for HIV. They additionally recommend screening for all pregnant individuals the first time they're pregnant, or even if they're presenting in labor and have not had an HIV test, they should have an HIV test at that time. And then additionally, an HIV screen should be repeated with each pregnancy. The USPTF didn't give a strong determination or recommendation about repeat testing, but they do generally recognize that anybody at increased risk of requiring HIV or somebody who's living and receiving medical care in a setting that has high prevalence of HIV, which Maine doesn't qualify under that, but people who have these prior, the CDC identified risk factors that I talked about are supposed to get repeat screening. It's just, unfortunately, it doesn't carry a grade A recommendation from the USPTF, but I have not found difficulty in getting insurance coverage, and the cost of HIV screening has gone down, so this is not usually a barrier. I want to just briefly talk about 2 laws in the state of Maine that impact HIV testing, and this is like a ton of text, so I'm going to highlight the important parts here. But regarding consent, or more specifically assent for HIV testing, there are statutes that require that an HIV test be voluntary and undertaken only with the patient's knowledge and understanding that an HIV test is planned. The statute goes on to explain that some information should be available to the patient, particularly information that includes an explanation of what HIV infection involves and the meaning of a positive and a negative test result. I think that this can be quite daunting for many providers. It feels like a lot needs to happen, or maybe sort of extra stigma is attached to HIV testing, which I actually don't like because I think it causes a stickiness and might decrease the frequency of testing. So I think it's just important to develop a script. Mine is basically, hello, sir. I'm happy to see you and we're sending some blood work for XYZ diagnosis. It includes basic chemistry. I'm going to be checking your cell counts. And either because of your presentation or because I recommend it for all of my patients, I will also be doing an HIV test. Do you have any questions about that? And that's usually enough. Patients don't even have to give a verbal yes. They just have to have an opportunity to say no. In 2023, last year, an additional law was passed in the state of Maine that further complicates this. So it's still subject to that consent requirement, which I think, well, may have been slightly short-sighted in the law, but I'm no lawyer or legal legislator. But this says that all healthcare providers shall include an HIV test in the standard set of medical tests performed when an individual is being seen for possibly sexually transmitted infection. I think this is slightly vague. There's not exactly a standard set of medical tests, but in Maine Health, for instance, the way we've implemented this is actually that we have a pop-up in our electronic medical record that says to people who are ordering other STI testing that they may need to include an HIV test as well. So how do you test for HIV? So testing for HIV includes several options, predominantly a blood test, and there are several blood tests available. Most labs are using what's called a fourth generation test. So this includes an ability to detect both the HIV antigen or AG and antibodies made by the individual against HIV. So an antigen antibody combination. This has been shown to be more sensitive. It can detect HIV earlier compared to when the person became infected, and generally is the most prevalent test. There is an older third generation test that may still be available in certain labs. So this just lacks that antigen testing. And I'll show you some data on sort of how that affects when somebody could turn positive. And just, I've not seen this as often. There's also the possibility to send a direct viral load. It's not usually done, although in certain circumstances it may be appropriate. A negative HIV viral load in somebody who's not taking any medicine that would affect HIV, so any antiretroviral medicine, would be high specificity and sensitivity for HIV infection. There is also an oral swab that can be done both as a point of care test or actually it's available over the counter. Patients can, it's FDA approved to be done at home. So some people find this, useful for the privacy and being able to be at home. It does require confirmation. So both the fourth generation, third generation tests would normally be confirmed by the lab as a reflex, or if it's done in the office as a point of care test and is positive, it's important to send those patients to a lab where a Western blot, or sort of more specifically a antibody confirmation will get done. That will determine whether it's HIV-1 or 2, although 99.9% of infections in the United States are HIV-1. And anybody who had a home test should also be sent to the lab as well. So these tests talk about, or it is important to appreciate something called a window period. So after an HIV infection, if an event or transmission occurred on, say, day 0, it can take some time for tests to become positive. And so there's the possibility of a negative test being done kind of anywhere in this gray zone here if it's too soon after the infection. HIV RNA is the most sensitive, so that HIV viral load is typically positive around 10 days after infection. Again, as long as the person's not taking PrEP or PEP, that is very sensitive. It takes a little bit longer for the antigen antibody combination tests, and typically the lab tests are slightly more sensitive or can detect it slightly earlier than the point of care versions. These are uniformly better than the antibody alone test. And then the confirmatory test, that Western blot, can take up to a month to turn positive. And so there are rare cases where you might have like a early positive here and then a negative on the confirmatory, and we typically just repeat those and or get a viral load. For any difficult tests, please reach out to experts, but I just want people offering the test to be aware of these sort of window periods because it helps also to explain to patients. There's an algorithm available from the CDC and the Association of Public Health Laboratories that talks about this, but essentially The current recommendation is to use the fourth generation test, or this algorithm is based on the fourth generation test. It's still appropriate. It can be appropriate to use the third generation test. We just don't see as many of those. A negative is negative. Depending on the situation, it may warrant a repeat, again, because of that window period. A positive goes on to confirmatory differentiation assays. And then if any of these are very difficult to confirm, a nucleic acid test or PCR can be done as well to try and confirm. So what should you do for a positive antibody test or for an HIV test result? Again, 99 times out of 100, you're going to be giving negative results. The CDC recommends a status neutral approach to this. I recommend and sort of consider just discussing with patients, it's the situation. Are they very worried? Are they expecting something? Or are they very savvy? They get on their MyChart really quickly and look at their results, and they'll be completely fine if they see a negative. Otherwise, it could be appropriate to call when you have other results and just say, by the way, this was negative, or somehow communicate that. On the off chance that you see a positive, it is important to know that there's going to be some confirmatory testing that will be done by the lab. Like I said, also all point of care tests need to be sent to the lab. And so this is a period where things can be very stressful. So lab results may show preliminary positive on that antibody antigen test, and you're waiting often about a day or two for the confirmatory testing. It's worth, when patients call or in these situations, advising people that the confirmatory test needs to be done. And I do go so far, depending again on the situation and what I'm expecting for the patient to explain, that it's very common for tests to be false positive. So almost 80% of positive tests in a low prevalence setting are actually false positive tests. The better number to point out is that that's 0.8% of all tests that are done can be false positives. So if you send 1,000 tests, you will get 8 false positives. And depending on the prevalence, you may get 1 to 2 true positives. And so it's just, I think, useful to say to patients, again, depending on their situation, this may be false positive. Please just wait. We're going to get the confirmatory testing. I'll let you know as soon as we have that. People who are repeatedly false positive may want to use a different platform. So something like an HIV viral load only if there's concern there. You can offer and sort of plan some initial orders, and I'll go into some more labs as well, but initially plan to order an HIV viral load and a CD4 count. That could be it. You could stop there and send the patient for further consultative care at an HIV clinic. But these are very helpful for us to have when we see the patient. So what can you tell somebody who has a true new HIV diagnosis to expect? And I think this counseling is also very important. I always emphasize to patients that somebody diagnosed with HIV today can expect a very long and healthy life, but they do need to remain in care and on therapy. I'll show this data, but recent life expectancy is almost normal compared to people without HIV and people with HIV who take their medication. I also emphasize to patients that there's no cure. They may see out there information about people who have been cured. That's a very rare thing. There's also times I've had patients with sort of translation issues where they thought undetectable meant cured. And so it's just important to emphasize that they're going to need to keep taking ART, antiretroviral therapy. You could kind of use as like a little hack or a little alternative to point out to patients that effectively taking a pill once a day cures the patient, because they will not then have side effects or immune deficiency from HIV. The virus stays in check, and the disease is essentially nothing but a chronic illness. As I mentioned, there are about 5 or 6 cases of people who have truly been cured. They required bone marrow transplants. It's extremely rare. There is a lot of like newsprint and journal articles about it because it's so interesting. So it's not unheard of that people see it. It's just not something that's feasible right now. Scientists are trying to understand what we can learn from those situations to actually try to more broadly cure patients. But again, I try to use the functional cure idea to help patients understand taking ART is very important. And then I also like to emphasize in that same conversation that staying suppressed, staying on ART and getting suppressed to a viral load less than 200 means that they cannot transmit HIV to sex partners. Again, that can just kind of help in the sort of immediate, what will my life look like moments that they get that information. I mentioned this briefly, and for time, I'll just go through it very quickly. So this blue line from a study just released in May of last year shows that for people, this is women who acquired HIV via sex and started ART after 2015. If they're age 40 at diagnosis, they can expect to live about 42 additional years compared to general population of 45.8. For cisgender men, that the delta is actually even smaller. So again, starting with a high CD4 count or a normal CD4 count, we often diagnose people with HIV, especially if they're tested frequently, with a CD4 count above 500. They can expect to have essentially a normal life span as long as they take their ART. Just briefly, initial labs. Any acutely ill patient should be referred for hospitalization because there's many tests that we have to do and it can be complex. But if they're ambulatory, ideally, we would like to connect them to HIV care at this time that they're informed of the diagnosis, and I'll give you some resources for that. If you felt like it, there are some basic labs that largely look like what you might expect: CBC, CD4, chemistry, urinalysis, and then we do some virus-specific and other STI testing at the first visit. But we can also arrange that as a consult for a new patient. This is from the panel on antiretroviral therapy agents, and it's a grade 1 recommendation that all patients who have HIV should take antiretrovirals in a grade A, but level of evidence 2, that starting ART immediately or as soon as possible after the diagnosis increases their sort of uptake, their willingness to keep on it, to take the medicine and stay on it. It increases the chance that they'll stay in care. And it also shortens that time to viral suppression, which decreases how much they could transmit HIV on to the next person. I mentioned that PrEP and NPEP are probably beyond the scope of this lecture, and for time, I just want you to know that there's a pre-exposure prophylaxis, which means taking a little bit less than a full regimen of ART on a daily basis. There's also an every other month injection, and it's very effective at preventing HIV acquisition when taken as prescribed. Non-occupational post-exposure prophylaxis is taking a complete ART medication for about 28 days. It needs to be started within 72 hours after a sexual encounter or accidental needle stick. And really, if anyone's coming to see you for NPEP, non-occupational PEP, consider offering them PrEP. There's a great resource for this. PrEP 207 is a Maine-centric resource. I also wanted to just briefly share national hotlines that are available sort of working hours for us, that you can rapidly get in touch with a clinician and get PrEP questions answered. And this is also that text number for the main version of PrEP. These are some clinics that already provide HIV care, and it's not an exhaustive list, but I wanted you to have places that you could potentially refer patients. Some self-learning resources. The University of Washington provides a national HIV curriculum at this website that's really fantastic. Modules you can pace yourself and even get CME and a certification. They've also just released a PrEP-based curriculum. And then I received some grant funding to do talks like this from the AIDS Education Training Center, specifically the NEATC. So other events and other recordings are available at our website here. And with that, I will pause, but just reinforce, please reach out if there's anything ever I can do to help.
Do we have any questions from anybody in the audience?
Launch the poll.
I think we'll go ahead. Thank you, Dr. Rawlings. As I mentioned at the beginning, Linda is going to launch a poll. So if you could go ahead and answer that poll question. And Linda, you can probably stop the recording now too.